So, the first thing to do is to introduce our keynote speaker for today, and that's Miss Elizabeth O'Brien. And Elizabeth O'Brien is a nurse practitioner from Royal North Shore Hospital. Liz has a very strong history in stroke, as she, along with her colleagues at Royal North Shore Hospital, set up the first stroke unit in Sydney in 1997. Liz has been involved with the development of stroke services throughout New South Wales through her many years of involvement in the Agency of Clinical Innovation Stroke Network. Liz has a strong commitment to quality stroke care and is passionate about follow-up for stroke survivors after their stroke. She now runs the TIA and Stroke Outpatient Clinic at Royal North Shore Hospital and has been involved for many years in research and also the support of her colleagues and staff in further education to ensure that they are providing excellent stroke services. She's always been passionate about stroke education, and it's my privilege to introduce Liz to you this morning. Please welcome her to the podium, and she will address the topic of the importance of medication in secondary prevention. Liz's talk will go for around about 45 to 50 minutes, and then we will allow time for questions after that. Welcome, Liz.
Hello everyone, and welcome online as well. It's a privilege to be here today, and thank you very much to Michelle and the Stroke Recovery Association New South Wales for asking me to present in this very highly valued spot as a keynote speaker, so I really appreciate that. Thank you very much. So Michelle has asked me to talk about the secondary prevention and medication in stroke, but as we all know, if you've ever been to me in my clinic and any clinics in regards to stroke, we don't just talk about medications, we also talk about lifestyle modification, because it's the lifestyle modification that goes hand in hand with those medications to help prevent stroke and TIA. So we'll start up. Thank you. Right, for me just to forward it on from here. Great, thank you. So we're going to talk about the importance of medications in secondary prevention post-stroke, but as I said, there's a lot more involved to just medication. Firstly, I just wanted to get us all on the same page. I know you've all had stroke or experience with stroke, working with stroke, being a survivor, being a carer, but it's always good just to go back and look at the basics and to look at why we're all here. So this is just some images that highlight the types of things that we're looking at when we talk about stroke. So the top image is ischemic stroke. So this is where we have a loss of blood supply to the tissue of the brain, the eye or the spine, which causes death of the cells that are responsible for our body's activities, such as moving, sensation, speech, vision, thinking and awareness. The second slide down shows a hemorrhage. So hemorrhagic stroke is where there is bleeding into the brain tissue or the layers of the brain, which causes pressure to the cells that inhibit their ability to work properly. So we get weakness, we get sensory changes as a result. And then subarachnoid hemorrhage, which is bleeding into the spaces that usually contains the fluid that protects the brain. The CSF. The blood in the CSF then causes irritation and subsequent damage to the brain. So I'm actually not going to be talking very much at all about subarachnoid hemorrhages, but I wanted to include it because I know there's a lot of people within the stroke recovery world, consumers, who actually have experienced subarachnoid hemorrhage, and they experience the same type of issues that ischemic stroke or hemorrhagic stroke have. So we'll keep them certainly within the radar, but that's certainly not what I'm talking about today. So there are other definitions that people use when talking about stroke. So minor stroke is what we talk about in the hospital when we're looking at someone who's presented to our emergency department. So we do an assessment and we do what's called an NIHSS, so the National Institute of Health Stroke Scale. And this helps us to determine the severity of the stroke, what we can do for these people who present to us, and give us an idea about how they're actually going to progress throughout their stay. So an NIHSS of less than or equal to 3 is considered a minor stroke. So this is where there are smaller deficits, so smaller issues to do with weakness or sensation, vision, speech, but they can still have significant impact on your post-stroke life. So for example, if you have a speech deficit where you are unable to get the words out, unable to understand the words, that has a huge, huge outcome for ongoing life. So, you know, not to, I never want to minimise stroke, so calling it minor stroke, if you've got a speech deficit, you probably won't think it's too minor at all, but that's where we come from with that. And then there is another terminology which is a bit of my pet peeve, mini stroke. And people often refer to TIA as a mini stroke, and I don't think that's actually quite correct terminology. If you have a TIA, so a transient ischemic attack, there is no stroke on imaging. And we usually go for an imaging diagnosis of stroke, and it usually means that the symptoms have recovered completely. I think it minimises the importance of recognising the risk of stroke, and it minimises the importance of stroke as a whole. So let's not do that, because everyone's important. So transient ischemic attack, or TIA, which is where I work at mostly these days. So this is a transient neurological dysfunction which is caused by focal brain, eye or spine ischemia. It's most likely caused by vascular disease in a known vascular territory of the brain. So some of those major arteries that supply blood to the brain is different types of different areas of the brain, different territories, we get different symptoms. A TIA is clinically diagnosed when symptoms resolve completely within 24 hours. And as I said, we now have radiological diagnosis where if we don't see a stroke on an MRI, it's a TIA. However, most TIAs who present, and I see a lot of TIAs in our stroke clinic, about 50% of these patients whose symptoms resolve quite quickly show a stroke on their MRI scan in our clinic. So we then have to change our We really don't change a lot of our management, but it's the terminology that then changes. Excuse me. So the risk of stroke in the first week after TIA is substantial. So there is a 25% risk of a vascular event or death within 90 days. Excuse me. 10% of people with a TIA have a major stroke within 7 days. And we know that urgent assessment and treatment reduces the risk of a stroke after a TIA by about 80%, and it's really important to manage these risk factors early. And the first-line treatment is antiplatelet therapy, so that's aspirin, clopidogrel, and that's usually commenced from the emergency department. It's also important to recognise the symptoms, and everyone should know what the FAST symptoms are, the FAST signs of stroke. So face, arm, speech and time. And this enables early access to stroke treatments that are available acutely. And these are thrombolysis, so the clot buster drug that everyone talks about, ECR or endovascular clot retrieval, and of course stroke unit care, which is one of the highest levels of improvement after stroke we have. So we'll talk a quick about acute treatment. So thrombolysis came about around about the 1995 era, so a long time ago, from the NINS trial. This is the National Institute of Neurological Disorders and Stroke. They found that thrombolysis, so IV TPA significantly improved the overall odds of a good stroke outcome at 90 days when it was given initially 3 hours and then expanded out to 4.5 hours of stroke onset. 114 more patients had a much more favourable outcome per 1,000 patients treated within 3 hours, and 51 more per 1,000 patients treated between 3 and 4.5 hours. And earlier treatment was associated with greater benefits. So it's important to recognise those symptoms, get to emergency early, so we can start seeing you and managing you early. So in 2003, after all of this, the studies in 1995, we finally had TGA approval in Australia to give thrombolysis. And that was a big uptick in what we were doing with stroke. So there are lots of publications that started out from the 1995 one until, until most recently, I think that was 2000 and I can't read the date, but anyway, it's in the early 2000s where we went out to 4.5 hours for giving TPA. So the recommendation from the Stroke Foundation is a strong recommendation, and this means that benefit outweighs the benefit outweighs harms for almost everyone, and most people would want to have this treatment. So for patients with potentially disabling ischemic stroke within 4.5 hours of onset who meet specific eligibility criteria, intravenous thrombolysis should be given as early as possible after stroke onset. So 3 to 4.5 hours is not long when it comes to working out what's going to be happening. So we all know how to run, don't we, Rebecca and Kylie and Danielle? So endovascular clot retrieval came along as well. So at Royal North Shore, we were doing endovascular clot retrieval for a long time before the studies showed that it was successful. But we now have very rigorous studies that show us how good it is. So for patients with ischemic stroke caused by a large vessel occlusion, so the internal carotid artery, the big arteries that run up through the neck, the middle cerebral artery in the brain, or occlusion of the carotid and intracranial large arteries. So endovascular thrombectomy should be undertaken when the procedure can be commenced within 6 hours of stroke onset. So we've got a little bit more time, but this is where they pop a catheter through the femoral artery at the top of your leg, up through the heart, up into the brain, grab the clot and pull it out. It's not as simple as that, I can tell you. So there's now clear and high quality evidence of improved functional outcome. So 229 more patients had functional independence per 1,000 stroke patients treated with ECR, so that's pretty good. There is a lower mortality, so 44 fewer patients died with every 1,000 stroke patients who were treated, and there was no evidence of increased risk of bleeding into the brain. So we've also now gone out to 24 hours for endovascular clot retrieval after the DAWN study. So these are for patients who are wake-up strokes, so people who wake up at 6 o'clock in the morning, last seen well, 10 or 11 o'clock when they went to bed. So the DAWN study in 2017 showed that endovascular thrombectomy should be undertaken when the procedure can be commenced up to 24 hours after they were last seen well or known to be well. And we again rely on radiology, so CT and or MRI, to see if there's evidence of salvageable brain tissue. And the outcomes for disability at 90 days were better with thrombectomy plus standard care, so that's what we would normally do, than with standard care alone. So they also then went on to have a look to see, do we need to give IV thrombolysis early at 3 or 4.5 hours and endovascular clot retrieval, or can we just go straight to clot retrieval? So they did a study called DirectSafe, and they actually stopped it early because they found that no, they didn't stop it early. At the end of the study, they found that the therapy with thrombolysis should be given while patients are preparing to go for clot retrieval. So they didn't find that there was any benefit in avoiding the IV thrombolysis. So if we can, we do both. We do IV thrombolysis and then go on to ECR. So then after all of that, we also have our stroke unit care. So there are lots of studies these days that have looked at stroke unit care. And in 2020, the stroke unit trialists from the UK looked at all these studies that looked at organised stroke care. And they found that per 100 patients, 2 more people were able to survive well if they'd been looked after in a stroke unit, and 6 more were living at home or living independently. So there is high-level evidence for stroke unit care. So stroke unit care is where you have staff, especially nurses, medical staff, allied health staff, who know what they're doing with these stroke patients, watch for complications and actually manage all their risk factors very acutely so that they can actually improve their outcome down the line. And so admission to a stroke unit for ischemic stroke patients results in significantly better recovery at 3 months without any significant difference in mortality. And patients with intracerebral hemorrhage seem to benefit as much as the ischemic stroke patients in a stroke unit as well, so providing all the care that we do there. So moving on to secondary prevention of stroke. That's a big jump, but that was my thing for today. So all this hyperacute and acute measures that we then do are supported by the recommended secondary prevention strategies with medications and the lifestyle changes to reduce the risk of a secondary stroke. So we know that someone who's had a stroke, within the first month to 3 months, are more likely to have another stroke if they don't manage their risk factors. So it's about trying to prevent that. So this is just a little bit complicated, but it's a table that gives an idea to see our thinking processes about which way we go with our patients. So the first line stuff that we do after thrombolysis and after endovascular clot retrieval is antiplatelets. So the function of antiplatelets, I can't say that today. When you get a cut, platelets rush to the wound. They become sticky, they bind together, and they form a clump to help stop the bleeding. This stickiness, though, can lead to blood clots, clogged arteries, heart attack and stroke as a result. So antiplatelets, so aspirin and clopidogrel are the 2 main ones that we use. They work by inhibiting the production of enzymes in the pathways that produce these platelets. And aspirin is the most common antiplatelet used, and in Australia we use a dose of 100 milligrams daily. I think in the US they use 75, someone else uses 125, but we use 100. So there are other antiplatelets such as clopidogrel, which I mentioned, or Plavix is the other name it's known as, that's a brand name. This most commonly inhibits platelet development, but it needs an enzyme within our body to convert it to its active form. So some people do not have adequate production of this enzyme to convert the clopidogrel to its active form and are known to be clopidogrel resistant. So we can do testing for this at some pathologies, and this can also guide how we manage our antiplatelet therapy. So we give antiplatelets as we can give them as primary prevention, but for this, after a stroke, we give as secondary prevention. So patients who have had an ischemic stroke who have not received thrombolysis should receive antiplatelet therapy as soon as the CT brain has excluded hemorrhage. So there's no bleeding in the brain that we're going to make worse by giving them something that stops those platelets from clumping together. So aspirin significantly reduces death and dependency and recurrent stroke, with a small increase in intracranial hemorrhage in patients with ischemic stroke who haven't had thrombolysis. It's recommended for secondary prevention after a TIA or ischemic stroke on the basis of many, many trials that show a 13% reduction in the long-term risk of recurrent stroke. Dual antiplatelet therapy. Now, this is where we combine aspirin and clopidogrel. This should be commenced within 24 hours, and it's used in the first 3 weeks in patients who have a minor stroke, so those strokes who have quite a low score on the assessment tool that we use, or a high-risk TIA to prevent stroke recurrence. It reduces non-fatal recurrent stroke in the first 90 days of approximately 1.9%. After that 21 days, we usually ask our patients to stop one of those antiplatelets, whether it's aspirin or clopidogrel. Most likely it's clopidogrel we ask them to stop, and to continue on aspirin lifelong. If someone's on clopidogrel, if they have a heart stent, they may need to stay on the clopidogrel to stop that stent from blocking off. So that's something that you all need to be aware of, and we need to be aware of, and liaise with the cardiologist if there's any concern. We don't give dual antiplatelet therapy if someone has had very, very large ischemic stroke, because the risk of bleeding into that stroke is quite high. So that's when we would just continue them just on the one medication, usually aspirin. So when it comes to secondary prevention, we look at these risk factors, and there are non-modifiable risk factors, which are age, gender, our genetics. We can't change those. Unfortunately, some people might think. Or there's modifiable risk factors. So this is where we can look at giving medical and non-medical therapies. So the main ones are hypertension, cholesterol, diabetes, those lifestyle factors of having a high saturated fat diet, sedentary lifestyle, smoking, alcohol, illicit drugs, a narrowing of the vessels in the neck, an irregular heart rhythm called atrial fibrillation, and heart structural problems such as a PFO or a patent foramen ovale. So we treat these risk factors either medically or non-medically. So medications treat the condition and maintain targets. We use procedures to repair those structural abnormalities if, again, people meet the right criteria for that. We encourage diet modification, we encourage exercise, smoking cessation, alcohol reduction, and illicit drug eradication. So let's talk about high blood pressure, hypertension. This is the leading cause of cardiovascular disease and premature death worldwide. I think there is an E on the end of worldwide. It's probably just behind my little picture. 25 to 50% of people with stroke have high blood pressure. There is a significant reduction in the risk of first and recurrent stroke with good blood pressure lowering treatment. Owing to the widespread use of antihypertensive medications, global mean blood pressure has actually remained constant or has decreased slightly over the past few decades. By contrast, the prevalence of high blood pressure has increased, especially in low and middle income countries. Estimates do suggest that about 31.1% of adults, which is about 1.39 billion worldwide, had hypertension in 2010. That's a lot of people. So the prevalence of high blood pressure among adults was higher in the low middle income populations at 31.5%, which is 1.04 billion people, than in high income countries with a comparison of 28.5%, or 349 million people. So hypertension can cause breaking of the small arteries deep in the brain, and this can cause a lack of blood flow, and often these are referred to as lacunar infarcts. If you've had a stroke or someone's looked at a scan and they said, oh, you've got some lacunar infarcts, often it's related to blood pressure. Hypertension can also cause breakage of the bigger arteries that have weakened over time due to high blood pressure flow. So high blood pressure puts a lot of stress on those arteries within our body, and it can weaken the walls of those arteries, and they can pop. So we use antihypertensives or blood pressure medications for hypertension. We aim to reduce blood pressure to reasonable targets. And so for those with a stroke or a TIA, a blood pressure lowering target of less than 130/80 millimetres of mercury is now the target since the 2017 American Heart Association guidelines came out. This is recommended after the depending on what's happening in regards to your, like someone's presentation with stroke, we do tolerate higher blood pressures because we want a little bit more flow up to the brain, but not catastrophic blood pressures. But that's a bit of a different kettle of fish. This is after all of that's happened. So if someone has come into us and we've stopped their usual blood pressure medications because we need to give some IV medications, we do need to restart someone's usual antihypertensives as soon as possible. We restart them within a few days after the stroke or TIA because this then reduces the risk of subsequent major vascular events. So we can use any of a number of medication classes to lower blood pressure. However, usually a diuretic, a class called ACE inhibitors or angiotensin receptor blockers, or a combination of the first two can be given. So we individualise the choice of blood pressure medications based on the patient, any concurrent medical issues, and as we can use this for primary and secondary stroke prevention. The PROGRESS study, which was done many years ago, showed that active therapy of blood pressure reduced stroke incidence by 28%. It's a lot. So how do blood pressure medications work? So beta blockers is one of the common ones that you might be on, or a friend might be on. So beta blockers make your heart beat slower and with less force. This reduces the amount of blood that's pumped through your arteries with each beat, and then this lowers blood pressure. It also blocks certain hormones in your body that can raise your blood pressure. And one of the common ones that people are on are metoprolol or Betaloc. Anyone on those medications? Yeah, there's a couple. So diuretics are the other medication that are used very commonly. So high sodium levels and excess fluid in your body can increase blood pressure. Diuretics, also called fluid tablets, they help your kidneys remove extra salts from your body, or sodium. As the salt leaves, extra fluid in your bloodstream moves into your urine, which helps lower your blood pressure. And so one of the ones that we use for that is hydrochlorothiazide, or HCT. It's often seen if you're on a combination medication. As the name of the medication, then HCT. ACE inhibitors are angiotensin converting enzyme inhibitors. So angiotensin is a chemical that causes blood vessels and artery walls to tighten and get very narrow. So ACE inhibitors prevent the body from producing as much of this chemical. It helps the blood vessels relax and it reduces blood pressure. And some of the common ones are ramipril, which is also tritase, or perindopril. So anything that ends in ril is normally an ACE inhibitor. Angiotensin II receptor blockers. So if you think back, ACE inhibitors aim to stop the creation of angiotensin. The angiotensin II receptor blockers, or ARBs, they block angiotensin from binding with receptors. And without the angiotensin, the blood vessels won't tighten up. They won't constrict. This helps relax the vessels and lower blood pressure. So some of the common ones for that are candesartan, which is also Atacand, or valsartan. So most of these end in artan. Alpha-2 agonists are another one, so methyl dopa or aldamet. is the normal medication for these. This type of medication changes the nerve impulses that cause blood vessels to tighten, and this helps the blood vessels to relax and then reduces your blood pressure. So my main points when it comes to taking your medications, your antihypertensives for secondary stroke prevention, is please take them as prescribed. They usually start at a low dose with a single agent, and then we increase the dose if the blood pressure still isn't controlled. So we might ask you to take your blood pressure at home a few days a week, write down those readings, take it to your GP so your GP can see if they need to increase the dose. Once you get to the maximum level of a medication, then we can start adding in other things to try and just get that blood pressure down. And if you are on the medication, as I said, check your blood pressure to make sure that the medication are achieving the targets. Don't just taking the blood pressure medication doesn't mean that it's instantly going to make sure your blood pressure is down to the right levels. Don't stop them suddenly. Okay, because all of a sudden, if you just decide that you've run out of your prescription and you can't see your GP for 3 weeks without blood pressure medication is a long time, and it puts you at risk of a stroke. There are side effects as with any medication, so the main one with antihypertensives is low blood pressure, which is why it's also good to check your blood pressure at home. So some of the medications that we use, so calcium channel blockers can cause some swelling in the limbs. Diuretics, besides making you want to go to the toilet, they can cause metabolic changes, so lack of sodium or potassium. ACE inhibitors can cause a dry cough, which is a bit annoying, so if that does happen, we can change you to something else. And some of the angiotensin receptor blockers can cause some kidney impairment. So it's always good to get your bloods checked regularly. So this is a question that is always asked of me. I can see Kylie nodding her head. My blood pressure is perfect. Do I still need to take my medication? Yes, is the answer. Because you know what? That's probably why your blood pressure is perfect, because you're on your medication. So high blood pressure can cause silent, long-term damage to the brain. It's called white matter ischemia, and if you get a lot of this white matter ischemia, it can cause vascular dementia as an end result. And that's just some image of what white matter ischemia looks like. All those little white bits around the sides, they shouldn't be there. So cholesterol is the next biggie. So the body produces cholesterol. It is also found in some foods, especially animal products. The liver is the main site for production of cholesterol. The human body uses cholesterol to build cells, but too much can put you at risk of vessel disease. Cholesterol is a waxy, fat-like substance. It's necessary to make hormones and vitamin D, and it helps you digest food. Too much circulating cholesterol can cause plaque development in the arteries, especially those supplying the heart and the brain. They can block the vessel and they reduce blood flow to the vital organs. And all that in that image that you've got over here, all that white stuff is cholesterol, it's plaque. So we look at the different types of cholesterol. And you will have, if someone's done your bloods and they've talked about your cholesterol, they'll talk about this. So LDL cholesterol is one of the main ones that we look at for stroke. This transports cholesterol from the liver to other parts of the body where it's used for various jobs. Any excess LDL can be stored. High LDL cholesterol levels are associated with a higher risk of cardiovascular disease, which is why it is frequently referred to as the bad cholesterol or unhealthy cholesterol. HDL cholesterol, which is referred to as good cholesterol, absorbs excess LDL and takes it to the liver, where it's broken down and leaves the body through the bile. A high LDL level is likely to have a positive effect on a person's risk of cardiovascular disease. which is why it's often referred to as good or healthy cholesterol. Triglycerides, these are the most common type of fat in the body. They store excess energy from your diet. A high triglyceride level combined with high LDL cholesterol or low HDL cholesterol is linked with fatty buildups within the artery walls, and this increases the risk of heart attack and stroke. And it can cause carotid stenosis if we have high levels of our of cholesterol in our system. It develops plaque which blocks the arteries to the brain and to the heart. We diagnose a carotid stenosis, so this is where it's important for us with stroke. By you can listen to the arteries with a stethoscope and you hear a sound called a carotid bruit. Don't use that as much anymore because we do have other techniques. So we can do carotid duplex ultrasound, and this looks at the flow through the vessel, and we can see if there's any plaque on the ultrasound. I do this in our clinic at Royal North Shore. If you come through ED, you might get a CT angiogram where they give you some contrast into your artery, and then it lights up all those vessels so we can see if there's any narrowing. Severe carotid narrowing can cause stroke, and if it's very severe, we'll likely need surgery. So we lower cholesterol to prevent carotid stenosis, which then helps to prevent stroke. We aim for an LDL of less than 1.8 millimoles per litre, an HDL of greater than 1, and a triglyceride less than 1.5. So how do we treat this? And we'll talk about diet and exercise as well, because they're really important for cholesterol. But we'll talk about statins. So this is HMG-CoA reductase inhibitors. HMG-CoA reductase regulates the production of cholesterol via lots of feedback within the body. It reduces production of and stabilises that plaque that has already developed in the arteries. And these are called statins. Everyone's probably heard about statins. Most people in here are probably on a statin. They're recommended nationally and internationally, both for primary prevention of cardiovascular events in people at increased risk of cardiovascular disease, and for secondary prevention in those with established disease. They are the most commonly prescribed medication in Australia. It's used by over 30% of the population aged 50 years and older. So there are lots of different medications that we can use. My favourite, I must say, is rosuvastatin. And on this table here, rosuvastatin is that top orange block, which shows that you get as good, if not better, reduction in your LDL cholesterol with a lower dose than some of the other medications. And rosuvastatin causes less of the side effects that everyone gets worried about. So the main ones we use in Australia are rosuvastatin, atorvastatin, simvastatin, pravastatin, and some of the others on there are not available here, or we don't use commonly. So they can cause mild side effects such as nausea. One of the main ones that everyone talks about, but it's very, very rare, is statin-induced muscle pain or aching. And this is where you have severe muscle necrosis because your body responds to the statin and it causes an enzyme production which then attacks the muscles. This severe muscle necrosis leading to this clinical muscle destruction is really rare. It only affects about 0.1% of patients, so it doesn't happen frequently. I think I've probably seen 2 that have actually been true statin-induced muscle necrosis, and that's in very decades of working in stroke. Statins can, it's been associated with diabetes, so there is a small increased risk of developing diabetes if you're on a statin. The risk is slightly greater than with intensive statin therapy than if you're on moderate statin therapy. Given the evidence from many clinical trials that statins reduce cardiovascular events in patients with diabetes, both randomised trials and observational studies suggest that the beneficial effects of statins on cardiovascular events and mortality outweighs any increased risk of diabetes. So it's better to be on a statin, decrease your risk of heart or stroke attack, because you're probably less likely to develop diabetes on it. And cognitive impairment was one thing that everyone was worried about with statins as well, and there's no real clear association of statins and cognitive deficits. So statins were a target of really bad publicity and social hype. And this was a catalyst program in 2013. Would you believe? People still talk about it. That's such a long time ago. It was called The Crux of the Matter. And there was an article, they looked at the outcome of this catalyst program. The Crux of the Matter, did the ABC's catalyst program change statin use in Australia? So the program in 2013 questioned the link between high cholesterol levels and cardiovascular disease and suggested that the benefit of statins had been overstated and the harms downplayed. Nearly 1.5 million Australians are estimated to have viewed each part of the program. I think it might have been in 1 or 2 sections. So a National Heart Foundation survey of 1,094 patients treated with statins found that 11% of patients who watched this catalyst program ceased taking their medication. An additional 12% stopped taking them but then eventually restarted them. And 12% reported starting to use natural remedies, which is fine as long as it's a healthy diet and exercise and you keep an eye on your levels, but natural remedies can be quite odd things out there. There were significant and sustained changes in statin dispensing following the area of this catalyst program. There were 2.6% fewer statins dispensed every week, which equates to 60,897 Australians who actually were affected by this program as a result of increased discontinuation of their medications, decreased initiation of the medications, or poor adherence, so decided. And many elements of the catalyst program content were inconsistent with the recommendations of key medical advice about statins and heart and stroke disease. So ABC actually withdrew the program. Thank goodness, because it caused a lot of problem. I can't believe we still talk about it, but we do. So despite ongoing bad press, rosuvastatin and atorvastatin, both lipid-modifying medicines, were among the most commonly supplied PBS medications in Australia in 2021-2022. So 15.2 rosuvastatin and 11.8 million atorvastatin. So keep an eye out for those side effects, but not every ache and pain is due to statins. That actually does you more benefit than harm. Diabetes is another risk factor. Is a chronic condition marked by high levels of glucose or sugar in the blood. It's caused by an inability to produce insulin, which is a hormone made by the pancreas, which controls blood glucose levels, or by the body's inability to use insulin effectively, or both. So there are type 1 diabetes, type 2 and gestational diabetes. In 2021, an estimated 1 in 20 Australians were living with diagnosed diabetes. So diabetes is a well-established risk factor for stroke. It can cause pathologic changes in blood vessels at lots of different locations within the body, and it can lead to stroke if the cerebral vessels are directly affected. It causes increased early age stiffness, systemic inflammation and thickening of those little tiny arteries within the membranes. In people who have type 1 diabetes, the pancreas does not make insulin. In type 2, which is the majority of patients that we see who have stroke or come into our clinics, the pancreas makes too little insulin, or muscles, liver and fat do not use insulin in the right way. As a result, people with untreated diabetes accumulate too much glucose in their blood, and their cells don't receive enough energy. So over time, this excessive blood glucose can result in increased fatty deposits or clots in blood vessels. So many patients are diagnosed with type 2 diabetes during their acute stay with us in the stroke unit, and we treat those high glucose levels acutely. We look at ongoing healthcare goals, which can include health education, nutrition, glucose control, the early detection of complications, cardiovascular risk reduction, and treatment of other conditions that people may have, such as obesity, the hypertension, and high cholesterol, etc. So the general target for an HbA1c, which is a long-term sugar marker, someone with type 2 diabetes should aim for less than 7%. Targets for monitoring blood glucose levels, so doing a little finger prick. Fasting, it should be between 4 and 7, and pre-meal blood glucose should be between 4 and 7, and after food it should be between 5 and 10. So the aim of management is for lifestyle measures primarily, such as diet, exercise, weight loss, smoking cessation, alcohol cessation. In addition to lifestyle modification, most people with type 2 diabetes eventually require some type of medications to control their diabetes. Just looking at time, I have to race. So diabetes and stroke. So if most people start on a medication called metformin, so I'm going to skip across to the medications because I'm running out of time. So we use some different hypoglycemics. So metformin is a biguanide, and this is one of the most common medications for diabetes, which is used initially, and it actually helps the insulin within your body. Metformin helps the insulin your body makes and supplements insulin work effectively. So it helps to reduce insulin resistance. Some of the other medications are the gliptins or SGLT2 inhibitors. So this medication increases the amount of glucose removed from your body through the kidneys. And sulfonylureas, these cause the pancreas to release more of your own insulin regardless of when you eat. So being hypoglycemia is quite common for these ones. We also look at atrial fibrillation as a risk factor for stroke. So this is where you have irregular heart rhythms that can cause an increased incidence of a blood clot in your heart. 1/6 of all strokes are attributable to atrial fibrillation. So we use anticoagulation for stroke prevention in atrial fibrillation. So we used to use warfarin all the time, but we now are very lucky to have direct oral anticoagulants, and these should be initiated in preference to warfarin for patients who have non-valvular atrial fibrillation. So as long as they don't have any valve disease, we can use these new medications. If you have a mechanical heart valve, you should still use warfarin. So we know that these new direct oral anticoagulants, prevention of stroke favours the use of the two dabigatran and apixaban that we use most commonly, rather than warfarin. So the main direct oral anticoagulants that we use are apixaban, which is a factor Xa inhibitor. This is given twice daily, either 5 milligrams or 2.5 milligrams. Again, don't stop the medication, continue it. Dabigatran, which is Pradaxa, also is used quite commonly. It involves the clotting cascade at a different part to the factor Xa inhibitors. Again, it's a twice daily dose, either 150 or 110 milligrams. And the other one that is used, but it's not hugely favoured by stroke, is Xarelto, which is a factor Xa inhibitor. It's a once daily dosing, which doesn't really give you much room for moving. So some good practice points. You must take them 12-hourly intervals. If you miss a dose, take it as soon as possible, but if it's closer to the next dose, wait and take it at your normal time. So warfarin inhibits vitamin K, and hence the activation of clotting factors reliant on vitamin K. Again, it's a once daily dosing. It has a longer time within the system as the other medications, and the dosing is ruled by blood levels. And I know I'm skipping over these, but I wanted to get to, I'm going to go past PFO. So PFO is an opening in the heart which hasn't closed when you're born, when you're a baby. And if you're under 60 and a PFO is found and you've had what looks like an embolic stroke, you may qualify to have the PFO closed. So medication compliance is really important. As I keep saying, don't stop taking these medications. Be guided by your GP. So they're usually lifelong. And again, if your blood pressure or your cholesterol are perfect, don't stop, because you know what? It's probably because of the medications. So just quickly looking at preventing stroke by healthy diet. Healthy diet lowers cholesterol and aids in weight loss. So it helps with blood pressure, it helps with diabetes management as well. So lots of fresh fruit and vegetables and whole grains, not as much animal fat. So exercise, this helps to lower weight, reduce your cholesterol and lower your blood pressure. So for adults between 18 and 64, they should be active most days, preferably every day. And each week, adults should do about 2.5 to 5 hours of moderate intensity aerobic activity. So it's about 30 minutes to 45 minutes a day. It's not long. It's a quick walk at lunch, round the block a couple of times, and you'll get there. Doing any physical activity is better than none. If you do no physical activity right now, start by doing some, build up to the recommended amount. So for older Australians, 65 years and over, again, stay active, as it's really important for all those things I've mentioned before, but it's also good for bone density, helps with balance as well, and it keeps your mind active. So again, we recommend about 30 minutes a day of moderate intensity aerobic activity. So a brisk walk, a swim, a cycle if you like, going on a bicycle, and try to reduce the amount of time you spend sitting down. Break it up as much as you can. And smoking cessation, do I need to say anything? Please stop. Okay, it doubles the risk of stroke if you're a smoker. And it increases heart attack double as well. So please stop smoking. Not good for you. Thank you, and questions. I think I made it.
Have any questions in the room for Liz? We have one. This gentleman over here.
How risky is a carotid endarterectomy?
How risky is a carotid endarterectomy? All surgical procedures carry a risk. I can't tell you off the top of my head because I'm not the surgeon, but it also depends on why you're having the carotid surgery. Obviously, it's a significant narrowing of the artery, so it's going to improve your risk of stroke phenomenally. So there is a high risk with any surgical technique, but I can't give you numbers, I'm sorry. I'm not good at numbers.
Hello. I was wondering, what do you think are the biggest barriers to medication adherence, and do you have any strategies to address those?
The biggest barriers to staying on medication, I think something that I see often is what I think I alluded to is that people just think that they're starting on medications and it's a course of medications. It's not antibiotics. Antibiotics, you take a course, you have to stop at a certain time. And I think it's that lack of understanding. Like, you just get told in hospital sometimes, oh, take this medication, and you get given 3 days worth, and unless it's made really clear you need to see your GP for continued prescriptions, some people just don't go and, get more of the medication. So I think it comes down to education and awareness, and also this aspect of, but my blood pressure's fine, why do I need to continue on the medication? It's down to where it should be. It's about making sure that there's understanding about why it's at a good point now and the benefit of continuing.
There's a gentleman down here. Gentleman down here, do we have any online? No. Okay. Can I just ask one while
Yep.
she's doing that? You indicated earlier the treatments, ER and TPA, etc. If you have one stroke and then you have another and you go back in, would you be eligible for those again if you'd had TPA and ECR before?
Usually if it's after 3 months. Yeah, yeah,
Yes.
yeah,
Thank you.
definitely.
What are the long-term side effects of medication? I'm not talking about, headache or just a short term, but I'm talking about the long-term, side effect, complication of the medication.
Well, every medication has their own complications and side effects, and every person is very different to their response to those medications. I think probably rather than thinking about what are the long-term complications of medications, I think you should think about what are the long-term benefits of medication. Because if you've got a complication of a medication, that should be recognised and you should either stop or change your medication so that you're on a medication for a reason. So if you're having a side effect with one of the blood pressure medications, like you develop the dry cough that I mentioned, I can easily stop that one that's causing the cough and move you to another one. So I know what you're asking, but that's probably a little bit hard for me to quantify.
We just have one online at the moment, and then we'll come back to Marnie. Oh, and then you.
We just got a question online regarding the risk of stroke from contraception pills. Can you speak a little to that?
Yeah, sure. So oral contraceptive pills are hormonal based, obviously, and hormones can increase the risk of developing a clot, so thrombosis, especially if it's teamed with smoking. So the combination gives you a very high risk of stroke. So if you're on an oral contraceptive pill and you no longer need to be on it, or you've had a stroke for whatever reason, then we would ask you to stop the oral contraceptive pill, use alternative contraception instead.
Could you comment, please, on vaping?
Vaping,
Vaping.
bad. I did actually have that on my smoking slide, but because I ran out of time. Vaping, these vapes are full of chemicals that we really don't know what they do. Some of them, they've even aligned them to being like paint stripper. So vapes have now been banned, I think. The import of vapes has now been banned, and I hate the damn things. So please don't vape. Huge. We don't know the risks of that, and we're not going to know probably for years down the track. But it's like smoking. When smoking everyone thought it was fashionable back when everyone had cigarettes, and the long-term complications and issues with smoking didn't come out for 50 plus years. So we don't know what's in vapes. Don't have them. They're rubbish.
And shisha, that Lebanese type smoking, and also marijuana.
Okay, marijuana. Yeah, marijuana, I'm not sure about it, but I mean it still would have an impact. Lungs, mouth, brain, definitely. So none of that. Bad for you.
I had an ischemic stroke and was told that thrombolytic therapy was not appropriate, and yet you're saying there that it would have been. Okay.
It depends. As I said, we have to do an assessment for people when they come in to see us. So it's a page-long checklist that we have to fill out. And we look at age doesn't come into it very much these days at all. We look at how well people were before this this presentation, we look at their other risk factors, we look at the time from when someone has had the symptoms of stroke to the time that they've presented, because we've only got 4.5 hours to actually give that medication. After that time, it becomes off-label, and so that carries a risk. So I don't know about your particular circumstances. So, I would probably think that might be, if you wanted to talk to your neurologist about it, just to clarify, but there may have been something that would have stopped them from doing that. Or, depending on how long ago you had your stroke, we weren't doing it until 2003. So...
Hi there. And with COVID, sort of the fact that people now just think of it as another cold, but there has been a link between COVID and an increase in risk of stroke. Can you talk to that at all?
I think COVID increased the severity of the ischemic strokes that were presenting worldwide. I think if Kylie or Rebecca or if you have any other information, I know that there was an increased risk of severity. We actually had a drop in patient presentations during COVID time, and obviously we've then had delayed. But if any of my colleagues have anything...
Carla will answer a little bit.
We found through ambulance that it was people delaying the amount of time. They didn't want to go to hospital because COVID was there, so the strokes were evolving much before they called.
Yeah. And
Just down to Kylie to answer a little bit more on that one.
So COVID increased your risks of getting clots, and there was 2 countries in the world that showed an increase in presentations with LVOs, but in Australia we actually didn't show any real links between COVID and stroke. So it was very few. I think I had 1 in the entire time that we put down to COVID.
Yeah. I think it was UK and America, were they the one, and China, yeah.
Any further questions online, Lani? Okay, Judith, sorry.
I just wanted to go back to the clot risk with hormone tablets.
Mm-hmm.
Does that apply equally to hormone replacement that is a compounded natural ingredient?
I'm not sure about the compounded versions, but I know hormone replacement therapy, again, increases the risk of stroke because it causes more thrombosis. And if you're on hormonal replacement therapy for menopause symptoms, things like that, they usually only recommend for as short a time as possible and usually no more than 12 months. In saying that, I see people who in their 70s and 80s who are still on their hormone replacement tablets and they haven't been stopped from them. So it still carries a risk for stroke and heart attack as well. I'm not sure about the compounded varieties that you're talking about though.
So one more question online.
So from a question online, is it required to completely cease alcohol post-stroke, or is there room for small amounts of alcohol intake?
For someone who likes bubbles, everyone can have a little bit every now and again. The World Health Organization actually says there's no safe level of alcohol intake, and alcohol abstinence is preferable. The Australian guidelines for men say no more than 2 standard beverages, which is, if you're drinking wine, it's 125 mils, which is a little bit. So for men, 2 on 5 days a week. For women, no more than 1 on 5 days a week. So
We count.
don't count tonight at the cocktail party. So look, I think with this, everyone needs to be sensible. Everything within moderation. It's like when we talk about, your diet. Look, of course you can have a piece of cake on your birthday or a bit of pudding at Christmas and the occasional bits and pieces. We don't want to make your life miserable, but I think it's all about using common sense, which I think there's actually becoming less and less common sense in the world these days. So use common sense, and actually if you just have a little bit of alcohol, that's fine, and a little bit of cream on your scones with jam and cream, that's fine. But don't make it an everyday thing, and don't have too much. Two.
We might finish up there.
Yep. Thank you, Michelle.
Thank you, Liz.